Question 1. What factors determine the appropriate scope and admission criteria for intensive care services within the European context, considering the dynamic nature of critical illness and the need for equitable resource allocation? Option A. The presence of specific, predefined diagnoses commonly associated with critical illness. Option B. A fixed duration of expected stay in the intensive care unit based on general patient population. Option C. The availability of intensive care unit beds and staffing levels at the time of patient presentation. Option D. A comprehensive assessment of patient acuity, reversibility of critical illness, and potential for meaningful recovery. The correct answer is D. A comprehensive assessment of patient acuity, reversibility of critical illness, and potential for meaningful recovery. Explanation. The scenario of defining intensive care is professionally challenging because it involves balancing limited resources with the complex and evolving needs of critically ill patients. Establishing clear criteria for admission and discharge is crucial for ensuring equitable access to high-dependency care, optimizing patient outcomes, and maintaining the sustainability of intensive care units, EDIC. This requires a nuanced understanding of patient acuity, prognosis, and the potential benefit of intensive interventions, all within the framework of established medical guidelines and ethical principles. The correct approach, focusing on a comprehensive assessment of patient acuity, reversibility of critical illness, and potential for meaningful recovery, represents best professional practice. This aligns with the core principles of intensive care medicine as understood within the European context, emphasizing the provision of advanced physiological support and monitoring for patients with life-threatening organ dysfunction. Such an approach prioritizes patient benefit and resource allocation based on objective medical criteria, reflecting a commitment to both individual patient well-being and the efficient functioning of the healthcare system. An incorrect approach that solely relies on the presence of a specific diagnosis or a fixed duration of illness fails to acknowledge the heterogeneity of critical illness. Many conditions can lead to critical illness, and the severity and reversibility vary greatly. Limiting intensive care based on a predefined list of diagnoses would exclude patients who are critically ill but do not fit neatly into those categories, potentially leading to suboptimal outcomes. Similarly, a fixed duration of stay ignores the dynamic nature of critical illness. Some patients may require prolonged intensive care for recovery, while others may stabilize and be ready for step-down care sooner than a predetermined timeframe. These approaches represent regulatory and ethical failures by potentially denying necessary care based on arbitrary criteria, violating principles of beneficence and justice. Another incorrect approach that prioritizes resource availability over clinical need is also professionally unacceptable. While resource limitations are a reality in healthcare, the primary determinant for intensive care admission and continued stay must be the patient's clinical condition and potential for benefit. Using resource constraints as the primary decision-making factor for admission or discharge can lead to rationing of care based on factors other than medical necessity, which is ethically problematic and can compromise patient safety. This approach fails to uphold the duty of care owed to critically ill patients. The professional decision-making process for similar situations should involve a multidisciplinary team approach, utilizing validated scoring systems for patient acuity, considering the reversibility of organ dysfunction, and evaluating the patient's overall prognosis and potential for recovery. Ethical considerations, including patient autonomy and the principle of distributive justice, must be integrated into the decision-making process. Regular reassessment of the patient's condition and response to treatment is essential to ensure that intensive care is provided only when indicated and for the appropriate duration. Question 2. When evaluating the optimal organization and structure of an intensive care unit (ICU) to enhance patient outcomes and operational efficiency, which of the following stakeholder-informed strategies best aligns with European standards for critical care provision and continuous quality improvement? Option A. Implementing a comprehensive, multidisciplinary needs assessment that incorporates data analysis, staff feedback, and patient outcome metrics to inform strategic planning for staffing, resources, and service delivery models, with a commitment to ongoing evaluation and adaptation based on evidence. Option B. Restructuring the ICU's organizational framework primarily based on physician-driven directives, with limited formal consultation with nursing staff or allied health professionals, assuming their roles are secondary to medical decision-making. Option C. Prioritizing immediate cost-saving measures by reducing nursing staff ratios and deferring equipment upgrades, based on a short-term financial outlook, with the expectation that operational adjustments will naturally follow. Option D. Focusing solely on increasing ICU bed capacity without a corresponding increase in specialized personnel or essential equipment, based on a perceived demand, without a thorough analysis of existing resource utilization or patient acuity. The correct answer is A. Implementing a comprehensive, multidisciplinary needs assessment that incorporates data analysis, staff feedback, and patient outcome metrics to inform strategic planning for staffing, resources, and service delivery models, with a commitment to ongoing evaluation and adaptation based on evidence. Explanation: this scenario is professionally challenging because it requires balancing the immediate needs of critically ill patients with the long-term strategic planning and resource allocation within a complex healthcare system. The EDIC framework emphasizes a holistic understanding of intensive care, extending beyond direct patient care to encompass the organizational and systemic factors that influence outcomes. Careful judgment is required to ensure that decisions regarding ICU structure and organization are evidence-based, ethically sound, and aligned with patient safety and quality improvement principles, all within the context of European healthcare standards and guidelines relevant to intensive care. The correct approach represents best professional practice because it prioritizes a multidisciplinary, evidence-based strategy for ICU organization. This involves engaging all relevant stakeholders, including medical staff, nursing staff, allied health professionals, and hospital administration, to ensure a comprehensive understanding of current needs and future demands. It also necessitates a commitment to continuous quality improvement, utilizing data to inform decisions about staffing, equipment, bed capacity, and service models. This aligns with the EDIC emphasis on best practices and the ethical imperative to provide the highest possible standard of care within the available resources, adhering to European guidelines on critical care provision. An incorrect approach that focuses solely on immediate cost reduction without considering patient outcomes or staff well-being would represent a significant ethical and professional failure. This could lead to understaffing, inadequate equipment, and ultimately, compromised patient safety, violating fundamental principles of medical ethics and potentially contravening European directives on patient safety and healthcare quality. Another incorrect approach that ignores the input of nursing staff or allied health professionals would be a failure to recognize the essential role of the entire multidisciplinary team in delivering effective intensive care. This oversight can lead to suboptimal workflows, communication breakdowns, and decreased staff morale, negatively impacting both patient care and the overall functioning of the ICU, and failing to adhere to the collaborative spirit promoted in European critical care standards. A purely physician-centric approach, neglecting the expertise and perspectives of other critical care professionals, also fails to meet the comprehensive requirements of modern intensive care organization as envisioned by the EDIC. The professional reasoning process for similar situations should involve a structured approach. First, clearly define the problem or objective related to ICU organization. Second, gather relevant data and evidence, including patient outcomes, resource utilization, and staff feedback. Third, identify and engage all key stakeholders, ensuring their perspectives are heard and considered. Fourth, develop potential solutions or organizational models, evaluating them against established quality indicators, ethical principles, and relevant European guidelines. Finally, implement the chosen approach with a robust monitoring and evaluation framework to ensure ongoing effectiveness and facilitate further improvements. Question 3. Quality control measures reveal a pattern of delayed initiation of hyperosmolar therapy in patients with acute traumatic brain injury and confirmed elevated intracranial pressure, EIP, exceeding 20 mmHg, despite adequate initial resuscitation and airway management. Which of the following represents the most appropriate immediate management strategy to address this quality issue and improve patient outcomes? Option A. Prioritize aggressive fluid resuscitation to improve systemic hemodynamics, even if it risks exacerbating cerebral edema. Option B. Focus solely on optimizing ventilation parameters to achieve normic apnea, assuming this will adequately manage the elevated ICP. Option C. Delay definitive ICP management until a surgical consultation is deemed absolutely necessary, relying on sedation alone for patient comfort. Option D. Implement a standardized protocol for the prompt administration of hyperosmolar therapy e.g. mannitol or hypertonic saline, once ICP thresholds are met, alongside continuous reassessment of CPP and neurological status. Correct answer is D. Implement a standardized protocol for the prompt administration of hyperosmolar therapy e.g. mannitol or hypertonic saline, once ICP thresholds are met, alongside continuous reassessment of CPP and neurological status. Explanation. Scenario analysis. Managing increased intracranial pressure EIC. In the intensive care unit ICU, presents a significant professional challenge due to the delicate balance required to maintain cerebral perfusion pressure CPP, while addressing the underlying cause of the ICP elevation. Rapid and accurate assessment, coupled with timely and appropriate interventions, is critical to prevent secondary brain injury. The complexity arises from the multifactorial nature of ICP, the potential for rapid deterioration, and the need for continuous monitoring and adjustment of treatment strategies, all within the ethical framework of patient care and resource allocation. Correct approach analysis. The correct approach involves a systematic, evidence-based strategy that prioritizes interventions known to be effective in reducing ICP and improving neurological outcomes, aligning with established European guidelines for the management of severe traumatic brain injury and other conditions causing elevated ICP. This includes optimizing cerebral perfusion pressure through appropriate fluid management and vasopressor support, controlling intracranial volume by addressing potential sources of edema or mass effect, and managing systemic factors that can exacerbate ICP, such as fever or seizures. Adherence to these guidelines ensures that patient care is delivered according to the highest professional standards, minimizing the risk of iatrogenic harm and maximizing the potential for recovery, in line with the principles of good medical practice and patient safety, as expected within the European context of intensive care medicine. Incorrect approach is analysis. One incorrect approach would be to solely focus on pharmacological agents to reduce ICP without addressing the underlying etiology or optimizing CPP. This fails to meet professional standards as it neglects a comprehensive management strategy, potentially leading to inadequate ICP control and worsening cerebral ischemia. Ethically, it represents a failure to provide holistic care and may violate the principle of beneficence by not employing the most effective available treatments. Another incorrect approach would be to aggressively lower blood pressure to manage systemic hypertension without considering its impact on CPP. This could lead to a dangerous reduction in cerebral blood flow, exacerbating secondary brain injury, which is a direct contravention of the principle of non-maleficence. Professional guidelines universally emphasize maintaining adequate CPP, and such an intervention would represent a significant deviation from best practice. A third incorrect approach would be to delay or omit neurological monitoring, such as ICP monitoring or regular neurological assessments, in favor of less invasive measures. This risks missing critical changes in the patient's neurological status, delaying necessary intervention, and potentially leading to irreversible brain damage. This failure to monitor adequately constitutes a breach of professional duty of care and a disregard for established protocols for managing critically ill neurological patients. Professional reasoning. Professionals managing increased ICP must adopt a structured, iterative approach. This begins with a thorough assessment of the patient, identifying potential causes of elevated ICP. The next step involves implementing evidence-based interventions, prioritizing those that address the underlying pathology and optimize CPP. Continuous monitoring of ICP, CPP, and neurological status is essential to guide ongoing management and adjust interventions as needed. This decision-making process is informed by current European guidelines, ethical principles, and a commitment to patient safety, ensuring that interventions are both effective and appropriate for the individual patient's clinical context. Question 4. Strategic planning requires a comprehensive approach to managing critically ill patients, particularly when considering the allocation of intensive care resources. Which of the following best reflects the fundamental principles guiding such decisions within the European intensive care context? Option A. Focusing exclusively on immediate physiological stabilization, regardless of long-term prognosis or resource constraints. Option B. Maximizing the utilization of all available intensive care resources for every patient, without regard for potential futility or impact on others. Option C. Allocating resources based on the patient's age and perceived social contribution, irrespective of clinical prognosis. Option D. Prioritizing interventions that offer the greatest potential for meaningful recovery and quality of life, while considering the sustainability of resource utilization and the needs of other patients. The correct answer is D. Prioritizing interventions that offer the greatest potential for meaningful recovery and quality of life, while considering the sustainability of resource utilization and the needs of other patients. Explanation: this scenario presents a common challenge in intensive care medicine, balancing the immediate, life-sustaining needs of a critically ill patient with the long-term implications of treatment decisions, particularly when resource allocation becomes a factor. The professional challenge lies in the ethical imperative to provide the best possible care while acknowledging the finite nature of resources and the potential impact on other patients. Careful judgment is required to navigate these competing demands, ensuring that decisions are both clinically sound and ethically defensible within the European framework for intensive care. The correct approach emphasizes a holistic assessment of the patient's prognosis and the potential benefits of continued intensive care, weighed against the likelihood of achieving meaningful recovery and the impact on overall resource availability. This aligns with the principles of beneficence and non-maleficence, ensuring that interventions are truly in the patient's best interest and do not lead to unnecessary suffering or futile treatment. Furthermore, it respects the principle of justice by considering the equitable distribution of scarce resources, a key consideration in European healthcare systems. The decision-making process should be transparent and involve multidisciplinary input, including the patient, if capable, and their family, adhering to European guidelines on patient autonomy and shared decision-making. An incorrect approach that focuses solely on the immediate physiological stability without considering long-term outcomes or resource implications fails to uphold the principle of proportionality, risks prolonging suffering and consuming resources that could be better utilized for patients with a higher probability of recovery. Another incorrect approach that prioritizes resource conservation above all else, without a thorough clinical assessment of the individual patient's needs and potential, violates the principle of beneficence and could be seen as discriminatory. A third incorrect approach that relies on arbitrary criteria or personal bias, rather than evidence-based guidelines and ethical principles, is fundamentally flawed and breaches professional standards and regulatory expectations for fair and equitable care. Professional reasoning in such situations requires a systematic approach. First, a comprehensive clinical assessment of the patient's current condition, underlying pathology, and prognosis is essential. Second, an evaluation of the potential benefits and burdens of continued intensive care, considering the likelihood of achieving the patient's goals of care, must be undertaken. Third, the impact on resource availability and the needs of other patients must be considered within the context of established ethical frameworks and institutional policies. Finally, open and honest communication with the patient and their family, coupled with multidisciplinary team consensus, is paramount to reaching a shared and ethically sound decision. Question 5. The efficiency study reveals that a particular advanced therapeutic intervention in the intensive care unit has a significantly higher cost per life year gained compared to other available treatments for similar conditions. A patient presents with a complex, multi-organ failure that could potentially benefit from this intervention, but the prognosis remains guarded. The clinical team is aware of the efficiency study's findings, considering the ethical principles guiding intensive care practice within the European framework. What is the most appropriate course of action? Option A. Prioritize patients for the advanced intervention based on their perceived likelihood of long-term survival and quality of life, using the efficiency study as a primary determinant for resource allocation. Option B. Proceed with a comprehensive, individualized assessment of the patient's potential benefit from the intervention, considering their specific clinical status, goals of care, and potential for recovery, and discuss this with the patient and their family, irrespective of the efficiency study's findings. Option C. Limit the use of the advanced intervention based on the efficiency study, opting for a less resource-intensive treatment that offers a statistically better cost-effectiveness ratio, even if the individual patient might derive greater benefit from the more expensive option. Option D. Immediately discontinue consideration of the advanced intervention and focus solely on palliative care. As the efficiency study suggests, it is not a cost-effective use of resources for this patient's condition. The correct answer is B. Proceed with a comprehensive, individualized assessment of the patient's potential benefit from the intervention, considering their specific clinical status, goals of care, and potential for recovery, and discuss this with the patient and their family, irrespective of the efficiency study's findings. Explanation. This scenario presents a profound ethical challenge at the intersection of resource allocation, patient autonomy, and the principle of beneficence within the European intensive care setting. The core difficulty lies in balancing the perceived efficiency of a treatment with the individual patient's right to receive care deemed medically appropriate, even if it is resource-intensive. The EDIC framework, while not a specific legal code, is built upon widely accepted European ethical principles and guidelines for critical care, emphasizing patient-centered care, respect for dignity, and the avoidance of discrimination. The correct approach, which prioritizes a comprehensive, individualized assessment of the patient's needs and potential benefits, aligns with the ethical imperative to treat each patient as an individual and to avoid making decisions based on generalized efficiency metrics that could inadvertently discriminate against certain patient groups. This approach upholds the principle of justice by ensuring fair access to care and the principle of beneficence by acting in the patient's best interest, as determined by clinical judgment, not solely by economic considerations. It respects patient autonomy by ensuring that decisions are made collaboratively and with informed consent, where possible. An incorrect approach that solely relies on the efficiency study's findings to limit or deny treatment would fail to uphold several key ethical principles. Firstly, it would violate the principle of non-maleficence by potentially withholding beneficial treatment, leading to harm. Secondly, it would disregard the principle of justice by creating an arbitrary barrier to care based on a flawed metric that doesn't account for individual variability in response and outcomes. Thirdly, it could be seen as a failure to respect patient dignity and autonomy, as it reduces the patient to a data point in an efficiency calculation rather than a person with unique needs and rights. Such an approach risks contravening the spirit, if not the letter, of European guidelines that advocate for equitable and patient-focused care in critical settings. The professional decision-making process in such situations should involve a multifaceted approach. It begins with a thorough clinical assessment of the patient's current condition, prognosis, and potential benefit from the proposed treatment, irrespective of any efficiency study. This should be followed by a discussion with the patient or their surrogate decision makers, ensuring they understand the rationale for treatment, its potential benefits and risks, and any alternatives. Consultation with colleagues, including senior intensivists and ethics committees, is crucial for complex cases to ensure a balanced and ethically sound decision. The focus must always remain on the individual patient's well-being and rights, with efficiency considerations serving as a secondary factor in resource management, not as a primary determinant of individual patient care. Question 6. Operational review demonstrates a 65-year-old male patient admitted to the ICU with severe acute respiratory distress syndrome (ARDS), requiring mechanical ventilation. Despite initial settings of tidal volume 6 ml/kg predicted body weight, PEEP 10 cm H2O, and Phi O2 6, the patient remains profoundly hyposemic, PA O2 55 mmHg, with a respiratory rate of 24 breaths/min and a plateau pressure of 28 cm H2O. The patient exhibits significant work of breathing. What is the most appropriate next step in managing this patient's gas exchange and ventilation? Option A. Increase PEEP incrementally while monitoring for hemodynamic stability and plateau pressure, maintaining tidal volume at 6 ml/kg predicted body weight. Option B. Initiate continuous neuromuscular blockade to reduce oxygen consumption and work of breathing. Option C. Significantly increase tidal volume to improve alveolar recruitment and gas exchange. Option D. Reduce PEEP to 5 cm H2O to decrease intrinsic PEEP and improve expiratory flow. The correct answer is A. Increase PEEP incrementally while monitoring for hemodynamic stability and plateau pressure, maintaining tidal volume at 6 ml/kg predicted body weight. Explanation. Scenario analysis. This scenario presents a common challenge in intensive care, optimizing mechanical ventilation in a patient with severe ARDS. Professional challenge lies in balancing the need for adequate oxygenation and ventilation with the risk of ventilator-induced lung injury, VILI. The patient's clinical presentation, including refractory hypoxemia and increased work of breathing despite initial settings, necessitates a careful, evidence-based approach to ventilator management. The decision-making process must consider the underlying pathophysiology of ARDS, the principles of lung protective ventilation, and the potential consequences of both under- and overventilation. Correct approach analysis. The correct approach involves a systematic, stepwise adjustment of ventilator parameters guided by physiological principles and evidence-based guidelines for ARDS management. This typically includes increasing positive end expiratory pressure, PEEP, to improve alveolar recruitment and reduce shunt, while carefully monitoring for adverse effects such as barotrauma or hemodynamic compromise. Tidal volume should be maintained at a low level e.g. 6 ml/kg predicted body weight to minimize VILI. Respiratory rate may be adjusted to achieve target minute ventilation and pH. Sedation and analgesia are crucial to reduce patient ventilator asynchrony and work of breathing. This approach aligns with the European Resuscitation Council (ERC) guidelines and the European Society of Intensive Care Medicine (ESICM) recommendations for mechanical ventilation in ARDS, emphasizing lung protective strategies and individualized patient care. The focus is on physiological optimization and minimizing iatrogenic harm, which are core ethical and professional responsibilities in intensive care. Incorrect approaches analysis. Increasing tidal volume significantly without addressing PEEP or other factors would directly contradict lung protective ventilation principles, increasing the risk of VILI due to overdistension of already injured lung units. This represents a failure to adhere to established best practices and could lead to patient harm, a breach of the duty of care. Reducing PEEP to a very low level e.g. 5 cmH2O would likely lead to derecruitment of alveoli, worsening V/Q mismatch and hypoxemia. This approach fails to utilize a key tool for managing ARDS and could exacerbate the patient's condition, demonstrating a lack of understanding of ARDS pathophysiology and ventilation strategies. Initiating immediate neuromuscular blockade without a thorough assessment of the current ventilator settings and patient's physiological response is premature. While neuromuscular blockade can be useful in specific ARDS scenarios to improve synchrony and reduce oxygen consumption, it should be a considered intervention after other optimization strategies have been explored and deemed insufficient, and it carries its own risks. This approach bypasses a systematic problem-solving process and may mask underlying issues with ventilator settings. Professional reasoning. Professionals should approach this situation by first conducting a comprehensive assessment of the patient's current ventilatory status, including arterial blood gases, chest X-ray, and hemodynamic parameters. They should then systematically review and adjust ventilator settings based on established ARD-SNET protocols or similar evidence-based guidelines, prioritizing lung protective strategies. This involves a stepwise approach to increasing PEEP, ensuring adequate tidal volume, and optimizing respiratory rate. Continuous monitoring for patient response and potential complications is essential. If initial adjustments are insufficient, further interventions such as prone positioning or consideration of rescue therapies should be evaluated. The decision-making process should be collaborative, involving the multidisciplinary intensive care team and documented thoroughly. Question 7. The monitoring system demonstrates a cardiac index of 1.8L/min/m2, mean arterial pressure of 55 mmHg, central venous pressure of 14 mmHg, and a pulmonary artery occlusion pressure of 16 mmHg, with the patient exhibiting cool extremities and oliguria. Which of the following represents the most appropriate initial management strategy? Option A. Administer a fluid bolus and reassess hemodynamic parameters. Option B. Increase the dose of a vasopressor infusion. Option C. Initiate an infusion of a potent inotrope. Option D. Perform a bedside echocardiogram to assess ventricular function. The correct answer is A. Administer a fluid bolus and reassess hemodynamic parameters. Explanation. This scenario presents a common yet critical challenge in intensive care, interpreting complex hemodynamic data to guide immediate patient management. The professional challenge lies in synthesizing multiple physiological parameters, understanding their interrelationships, and making timely, evidence-based decisions that directly impact patient outcomes, all within the high-pressure environment of the ICU. The EDIC curriculum emphasizes a thorough understanding of hemodynamic principles and their clinical application, requiring practitioners to move beyond simple data recognition to sophisticated interpretation and intervention. The correct approach represents best professional practice because it prioritizes a systematic, integrated assessment of the patient's hemodynamic status. This involves not only recognizing abnormal values, but also understanding the underlying physiological mechanisms contributing to these abnormalities. By considering the interplay between preload, afterload, contractility, and systemic vascular resistance, clinicians can identify the root cause of the observed hemodynamic derangement and select the most appropriate therapeutic intervention. This aligns with the ethical imperative to provide patient-centered care based on the best available evidence and clinical judgment, as implicitly guided by the principles of good medical practice expected within the European context of intensive care. An incorrect approach that focuses solely on a single parameter, such as a low cardiac output, without considering other contributing factors, is professionally unacceptable. This narrow focus can lead to inappropriate interventions, such as administering inotropes when the primary issue is hypovolemia, potentially exacerbating the patient's condition. Ethically, this represents a failure to conduct a comprehensive assessment and a deviation from the standard of care, potentially violating the principle of non-maleficence. Another incorrect approach that relies on empirical treatment without a clear diagnostic rationale is also professionally unsound. While experience is valuable, treatment decisions must be grounded in physiological understanding and evidence. Randomly titrating vasoactive medications without a clear hypothesis about the cause of the hemodynamic instability can lead to unintended consequences and delay effective management. This can be seen as a failure to adhere to evidence-based practice and a potential breach of professional responsibility. Finally, an approach that delays intervention while awaiting further, non-critical investigations when the patient is hemodynamically unstable is professionally problematic. While thoroughness is important, the urgency of the situation in critical care demands prompt assessment and action. Prolonged observation without intervention in the face of significant hemodynamic compromise can lead to irreversible organ damage and poorer outcomes, failing to meet the standard of timely and effective care. The professional decision-making process for similar situations should involve a structured approach. 1. Recognize and validate the abnormal hemodynamic data. 2. Integrate this data with the patient's clinical presentation, including signs of organ perfusion and fluid status. 3. Formulate a differential diagnosis for the hemodynamic derangement based on physiological principles, e.g., hypovolemia, cardiogenic shock, distributive shock, obstructive shock. 4. Prioritize interventions based on the most likely diagnosis and the potential for immediate benefit or harm. 5. Continuously reassess the patient's response to interventions and adjust the management plan accordingly. Question 8. Stakeholder feedback indicates that junior intensivists sometimes struggle to integrate complex hemodynamic data with the overall clinical picture. When faced with a patient exhibiting a low cardiac output reading and elevated systemic vascular resistance, what is the most appropriate initial step in interpreting these findings? Option A. Immediately increase the dose of vasopressors to counteract the elevated systemic vascular resistance. Option B. Focus solely on the elevated systemic vascular resistance as the primary problem and adjust vasodilator therapy accordingly. Option C. Assume the low cardiac output is due to hypovolemia and initiate aggressive fluid resuscitation. Option D. Assess the patient's fluid status and cardiac contractility to determine the underlying cause of the low cardiac output and elevated resistance. The correct answer is D. Assess the patient's fluid status and cardiac contractility to determine the underlying cause of the low cardiac output and elevated resistance. Explanation. This scenario is professionally challenging due to the inherent complexity of interpreting hemodynamic data in critically ill patients, where multiple factors can influence readings. The EDIC curriculum emphasizes a holistic approach to patient management, integrating physiological understanding with clinical context. Misinterpreting cardiac output and pressure readings can lead to inappropriate therapeutic interventions, potentially harming the patient and deviating from best practice standards of care as outlined by European intensive care guidelines. The correct approach represents best professional practice because it prioritizes a comprehensive assessment that integrates invasive hemodynamic data with the patient's overall clinical status, including physical examination, other monitoring parameters, and response to interventions. This aligns with the EDIC focus on evidence-based medicine and patient-centered care, ensuring that decisions are not solely data-driven, but are informed by a thorough understanding of the patient's pathophysiology. Adherence to established European guidelines for hemodynamic monitoring and management is paramount. An incorrect approach that relies solely on a single parameter without considering the broader clinical picture is professionally unacceptable. This can lead to diagnostic errors and suboptimal treatment. For instance, focusing exclusively on a low cardiac output reading without assessing for adequate preload or contractility might lead to fluid administration in a patient with cardiogenic shock, worsening pulmonary edema. Similarly, attributing elevated systemic vascular resistance solely to vasopressor therapy without considering other causes like hypovolemia or impaired vasodilation is a failure to apply critical thinking. Such an approach risks violating the ethical principle of non-maleficence by potentially causing harm through misguided interventions. It also fails to meet the standards of professional competence expected of an intensivist, as defined by the EDIC framework, which requires the ability to synthesize complex information for effective patient management. The professional reasoning process for similar situations should involve a systematic approach. First, critically evaluate the accuracy and reliability of the hemodynamic monitoring device and the insertion of the catheter. Second, correlate the hemodynamic data with the patient's clinical presentation, including vital signs, urine output, mental status, and physical examination findings. Third, consider the patient's underlying condition and any ongoing therapies that might influence hemodynamics. Fourth, formulate a differential diagnosis for the observed hemodynamic profile. Finally, develop a management plan that addresses the most likely underlying cause, with continuous reassessment of the patient's response. This structured decision-making process ensures that interventions are targeted, evidence-based, and aligned with the best interests of the patient, adhering to the ethical and professional standards promoted by the EDIC. Question 9. The performance metrics show a sustained increase in mixed venous oxygen saturation, SVO2, to 85% in a mechanically ventilated patient with septic shock who is receiving aggressive fluid resuscitation and vasopressor support. The patient remains hypotensive with a mean arterial pressure MAP of 55 mmHg despite these interventions. What is the most appropriate next step in management? Option A. Initiate a trial of inotropic support to improve cardiac output. Option B. Consider reducing the vasopressor infusion rate and increasing the fluid bolus while reassessing for potential causes of decreased oxygen consumption. Option C. Obtain a lactate level to assess tissue perfusion. Option D. Increase the vasopressor infusion rate to achieve a higher MAP target. Correct answer is B. Consider reducing the vasopressor infusion rate and increasing the fluid bolus while reassessing for potential causes of decreased oxygen consumption. Explanation. This scenario presents a common challenge in intensive care, interpreting complex physiological data in the context of evolving patient status and limited resources. The professional challenge lies in synthesizing multiple data streams, understanding their interdependencies, and making timely, evidence-based decisions that optimize patient outcomes while adhering to established clinical guidelines and ethical principles. The pressure to act quickly, coupled with the potential for misinterpretation of subtle physiological changes, necessitates a systematic and analytical approach. The correct approach represents best professional practice because it prioritizes a comprehensive understanding of the underlying pathophysiology and its impact on organ systems. It involves a structured assessment that moves from general principles to specific interventions, considering the patient's overall clinical picture rather than isolated parameters. This aligns with the core principles of intensive care medicine, emphasizing patient-centered care, evidence-based practice, and continuous reassessment. Adherence to established EDIC curriculum principles, which focus on a holistic understanding of critical illness, is paramount. An incorrect approach that focuses solely on a single, abnormal parameter without considering its systemic implications fails to acknowledge the interconnectedness of physiological systems. This can lead to inappropriate or delayed interventions, potentially harming the patient. Ethically, This approach may breach the duty of care by not performing a thorough assessment. Another incorrect approach that relies on anecdotal experience or unverified protocols disregards the importance of evidence-based medicine and established guidelines, which are central to safe and effective critical care practice as promoted by the EDIC framework. This can lead to suboptimal care and potential patient harm. A third incorrect approach that prioritizes immediate, aggressive intervention without a clear diagnostic rationale risks iatrogenic complications and may not address the root cause of the patient's deterioration. This demonstrates a failure in clinical reasoning and adherence to a systematic diagnostic process. Professional decision-making in such situations should involve a structured approach. 1. Recognize and confirm the abnormality in the performance metrics. 2. Integrate this finding with the patient's overall clinical presentation, history, and other physiological data. 3. Formulate a differential diagnosis for the observed physiological derangement, considering the most likely pathophysiological causes. 4. Develop a management plan based on evidence-based guidelines and the specific patient context, prioritizing interventions that address the underlying cause. 5. Continuously monitor the patient's response to interventions and reassess the management plan as needed. This systematic process ensures that decisions are well-informed, patient-focused, and aligned with best practices in intensive care. Question 10. The audit findings indicate a significant variation in Glasgow Coma Scale, GCS, scoring documentation across different shifts and practitioners within the intensive care unit. What is the most appropriate strategy to address this implementation challenge and ensure consistent, reliable neurological assessments? Option A. Encourage senior clinicians to verbally correct junior staff at the bedside when they observe GCS scoring inconsistencies. Option B. Implement a mandatory structured training program for all clinical staff on GCS assessment, including practical demonstrations and competency-based evaluations, followed by regular refresher sessions. Option C. Conduct a retrospective review of all patient charts with documented GCS scores to identify individual practitioners with the most frequent discrepancies. Option D. Issue a general reminder to all staff via email about the importance of accurate GCS documentation and the potential consequences of errors. The correct answer is B. Implement a mandatory structured training program for all clinical staff on GCS assessment, including practical demonstrations and competency-based evaluations, followed by regular refresher sessions. Explanation. This scenario presents a common implementation challenge in intensive care, ensuring consistent and accurate neurological assessment, specifically the Glasgow Coma Scale, GCS, across a multidisciplinary team. The professional challenge lies in the subjective nature of GCS components and the potential for inter-observer variability, which can lead to misinterpretation of patient status, delayed interventions, and suboptimal outcomes. The audit findings highlight a systemic issue that requires a structured approach to improve practice. The correct approach represents best professional practice because it directly addresses the identified deficit through education and standardization, aligning with the core principles of patient safety and quality improvement mandated by European intensive care guidelines. These guidelines emphasize the importance of standardized assessment tools and continuous professional development to ensure consistent, high-quality patient care. By implementing a structured training program with competency assessment, the team aims to reduce variability in GCS scoring, leading to more reliable data for clinical decision-making and communication. This proactive measure fosters a culture of learning and accountability, essential for maintaining high standards in intensive care. An incorrect approach that relies solely on informal verbal reminders fails to establish a standardized understanding of GCS scoring. This is a regulatory and ethical failure because it does not provide the necessary structured education or objective assessment of competency. It leaves room for individual interpretation and perpetuates the variability identified in the audit, potentially leading to errors in patient assessment and management. This approach is insufficient to meet the professional obligation of ensuring all team members are proficient in essential clinical skills. Another incorrect approach, focusing only on reviewing individual patient charts without addressing the root cause of inconsistent scoring, is also professionally unacceptable. This reactive measure does not equip the team with the knowledge or skills to improve their assessment. It is an ethical failure as it neglects the responsibility to proactively enhance the quality of care. Furthermore, it fails to comply with the spirit of continuous quality improvement expected within European intensive care settings, which necessitates systematic interventions rather than superficial reviews. A third incorrect approach, which involves blaming individual practitioners for scoring errors, is detrimental to team morale and does not foster a culture of learning. This is an ethical failure, as it is punitive rather than constructive. It overlooks the systemic issues that likely contribute to inconsistent scoring, such as inadequate training or unclear protocols. Professional decision-making in such situations requires a systematic, evidence-based approach to identify and address performance gaps. This involves understanding the underlying causes of errors, implementing targeted interventions, and providing ongoing support and education to the entire team. The focus should always be on improving patient outcomes through collective professional development and adherence to established standards. Question 11. Cost-benefit analysis shows that advanced hemodynamic monitoring systems can detect subtle changes in circulatory function earlier than standard methods, potentially leading to timely interventions. However, their implementation is associated with significant capital and ongoing operational costs, as well as a potential for increased alarm fatigue among staff. Considering the European Diploma in Intensive Care Medicine (EDIC) framework, which approach to implementing such advanced monitoring in a critically ill patient with undifferentiated shock is most professionally justifiable. Option A. Implement advanced hemodynamic monitoring only after a clear, evidence-based indication for its use has been established, demonstrating a high likelihood of actionable data that will directly influence patient management and improve outcomes, while also considering the patient's overall goals of care and the potential for resource optimization. Option B. Immediately implement advanced hemodynamic monitoring for all patients presenting with undifferentiated shock, as the potential for early detection of critical events outweighs the associated costs and potential for alarm fatigue, aligning with a proactive approach to critical care. Option C. Defer the implementation of advanced hemodynamic monitoring until the patient's condition has stabilized or a specific diagnosis has been confirmed, as the costs and potential for alarm fatigue are not justified in the initial undifferentiated phase of critical illness. Option D. Prioritize the implementation of advanced hemodynamic monitoring based primarily on the availability of the technology within the institution and the perceived prestige of utilizing cutting-edge equipment, assuming that advanced technology inherently leads to superior patient care. The correct answer is A. Implement advanced hemodynamic monitoring only after a clear, evidence-based indication for its use has been established, demonstrating a high likelihood of actionable data that will directly influence patient management and improve outcomes, while also considering the patient's overall goals of care and the potential for resource optimization. Explanation. This scenario presents a common challenge in intensive care, balancing the potential benefits of advanced monitoring with its associated risks and resource implications. The professional challenge lies in making an evidence-based, patient-centered decision that aligns with the principles of good clinical practice and resource stewardship, all within the framework of European intensive care guidelines. The EDIC exam expects candidates to demonstrate an understanding of how to critically evaluate monitoring strategies, not just their technical aspects, but their impact on patient outcomes, safety, and the healthcare system. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based evaluation of the utility of advanced monitoring. This involves considering the specific clinical context, the potential for actionable data, and the patient's overall goals of care. European guidelines and ethical principles emphasize patient benefit, avoidance of harm, and the judicious use of resources. Therefore, a decision to implement or withhold advanced monitoring should be rooted in a clear understanding of its potential to improve patient outcomes, reduce complications, or facilitate more effective treatment, without introducing undue risk or burden. This aligns with the principle of beneficence and non-maleficence. An incorrect approach that focuses solely on the availability of technology without considering its specific application or potential benefit represents a failure to adhere to evidence-based medicine. This can lead to the technology trap, where resources are expended on monitoring that provides no clinically meaningful information, potentially diverting attention from more critical aspects of care, or leading to unnecessary interventions. Another incorrect approach that neglects to consider the patient's individual circumstances and goals of care fails to uphold the principle of patient autonomy and individualized care. Furthermore, a decision based purely on cost without a thorough assessment of clinical benefit would be ethically questionable, as it could compromise patient well-being for financial reasons. The professional decision-making process for similar situations should involve a structured approach. 1. Clinical assessment. Thoroughly evaluate the patient's current condition, underlying pathology, and potential for deterioration. 2. Evidence review. Consult relevant clinical guidelines, systematic reviews, and expert consensus on the efficacy and safety of the proposed monitoring modality for the specific clinical scenario. 3. Risk-benefit analysis. Weigh the potential benefits, e.g., early detection of complications, optimization of therapy, against the potential risks, e.g., invasiveness, false alarms, increased workload cost. 4. Patient-centered goals. Integrate the patients and their families' values, preferences, and goals of care into the decision-making process. 5. Resource stewardship. Consider the impact on healthcare resources and whether the proposed monitoring offers a justifiable return on investment in terms of patient outcomes. 6. Team discussion. Engage in multidisciplinary team discussions to ensure a consensus approach and shared understanding. Question 12. The audit findings indicate a pattern of delayed escalation of critical patient deterioration in the intensive care unit, with a significant number of instances where nursing staff reported concerns that were not addressed promptly by the medical team. This has led to a review of multidisciplinary team roles and communication protocols. Which of the following approaches best addresses these audit findings and promotes optimal patient outcomes within the European regulatory framework for intensive care practice? Option A. Introduce a new electronic patient record system with advanced alert functionalities, assuming this will automatically improve communication and ensure timely escalation of critical events. Option B. Conduct a series of individual performance reviews for nurses who did not escalate concerns according to perceived timelines, focusing on their adherence to existing, albeit unclarified, escalation procedures. Option C. Implement mandatory daily multidisciplinary ward rounds with a structured agenda that includes a specific time for nursing and allied health professional input on patient status and concerns, alongside clear protocols for immediate escalation of any identified critical changes by any team member. Option D. Reinforce the primary role of the intensivist in making all critical decisions, with nurses expected to document concerns but deferring immediate action until a physician explicitly authorizes it. The correct answer is C. Implement mandatory daily multidisciplinary ward rounds with a structured agenda that includes a specific time for nursing and allied health professional input on patient status and concerns, alongside clear protocols for immediate escalation of any identified critical changes by any team member. Explanation. This scenario presents a professional challenge due to the inherent complexity of intensive care medicine, where timely and accurate decision-making is paramount. The audit findings highlight a potential breakdown in communication and role clarity within the multidisciplinary team, which can lead to suboptimal patient care, increased risk of errors, and potential breaches of professional standards. Careful judgment is required to identify the root cause and implement effective solutions that align with the principles of patient safety and collaborative practice. The correct approach represents best professional practice because it directly addresses the identified audit findings by fostering a culture of open communication and clear role definition. This aligns with the European Resuscitation Council (ERC) guidelines and the European Society of Intensive Care Medicine (ESICM) recommendations, which emphasize the importance of a structured, multidisciplinary approach to patient management. Specifically, establishing clear protocols for communication, defining the responsibilities of each team member, physicians, nurses, allied health professionals, and implementing regular multidisciplinary team meetings ensure that all members are informed, can contribute their expertise, and understand their specific roles in patient care. This collaborative framework minimizes ambiguity, reduces the likelihood of errors, and promotes a holistic approach to patient management, thereby enhancing patient outcomes and adhering to ethical obligations of providing competent and coordinated care. An incorrect approach that focuses solely on physician-led decision-making without adequate input from other disciplines fails to recognize the value of diverse expertise in the ICU. This can lead to a hierarchical structure where critical information from nurses or allied health professionals might be overlooked, potentially resulting in diagnostic or therapeutic errors. Ethically, this approach may violate the principle of beneficence by not utilizing all available resources to optimize patient care. From a regulatory perspective, it could be seen as a failure to adhere to best practices in team-based care as advocated by professional bodies. Another incorrect approach that involves assigning blame to individual team members without a systemic review is counterproductive. While accountability is important, a punitive approach without understanding the underlying systemic issues, e.g., lack of training, unclear protocols, communication barriers, does not address the root cause of the audit findings. This can foster a climate of fear and discourage open reporting of errors or near misses, which is essential for continuous quality improvement. Ethically, it deviates from the principle of justice by unfairly penalizing individuals without a thorough investigation of contributing factors. A third incorrect approach that involves implementing new technology without addressing the fundamental issues of team communication and role clarity is unlikely to be effective. While technology can support communication, it cannot replace the need for clear protocols, defined responsibilities, and a collaborative team dynamic. This approach might be seen as a superficial fix that fails to address the core problem, potentially leading to wasted resources and continued suboptimal patient care. It represents a failure to apply a systematic and evidence-based approach to quality improvement, which is a professional expectation. The professional reasoning process for similar situations should involve a systematic approach to problem solving. This begins with a thorough analysis of the audit findings to identify the specific areas of concern. Next, it requires engaging the entire multidisciplinary team to gather perspectives and understand the contributing factors. Based on this understanding, evidence-based solutions should be developed and implemented, focusing on improving communication, clarifying roles, and establishing clear protocols. Finally, ongoing monitoring and evaluation are crucial to ensure the effectiveness of the implemented changes and to facilitate continuous quality improvement, aligning with the principles of patient safety and professional accountability. Question 13. Compliance review shows a 65-year-old male patient admitted to the intensive care unit with severe sepsis and acute kidney injury, presenting with hypotension, oliguria, and hyponatremia. Which of the following approaches best reflects current European guidelines for managing this patient's fluid and electrolyte balance? Option A. Restrict all intravenous fluids to maintenance rates only and administer hypertonic saline to correct the hyponatremia, given the presence of acute kidney injury. Option B. Initiate a continuous infusion of isotonic crystalloid at a rate of 150 ml/hour, monitor urine output hourly, and reassess serum electrolytes every 12 hours. Option C. Administer a 1-liter bolus of isotonic crystalloid immediately, followed by a continuous infusion of 100 ml/hour, and administer intravenous sodium chloride to correct the hyponatremia. Option D. Perform a dynamic assessment of fluid responsiveness. Administer judicious fluid boluses of isotonic crystalloid only if indicated by the assessment, and manage electrolyte abnormalities based on serial clinical and laboratory evaluations, considering the patient's renal function. The correct answer is B. Initiate a continuous infusion of isotonic crystalloid at a rate of 150 ml/hour, monitor urine output hourly, and reassess serum electrolytes every 12 hours. Explanation. Scenario analysis. This scenario presents a common yet complex challenge in intensive care, managing fluid and electrolyte balance in a critically ill patient with multiple comorbidities. The challenge lies in the dynamic nature of fluid shifts, the potential for iatrogenic complications from interventions, and the need to tailor management to individual patient physiology and evolving clinical status. The presence of renal impairment and cardiac dysfunction significantly complicates fluid management, increasing the risk of both hypovolemia and fluid overload, each with potentially life-threatening consequences. The need for accurate assessment and timely, evidence-based intervention requires a deep understanding of physiological principles and clinical guidelines. Correct approach analysis. The correct approach involves a systematic, evidence-based strategy that prioritizes accurate assessment of volume, status, and electrolyte derangements, followed by targeted interventions guided by established European guidelines for intensive care. This includes serial clinical assessments, e.g., urine output, vital signs, mental status, appropriate laboratory monitoring, electrolytes, renal function, acid-base status, and judicious use of diagnostic tools, e.g., echocardiography for cardiac function, potentially less invasive dynamic measures of fluid responsiveness if indicated and available. Interventions should be guided by the principle of achieving euvolemia and correcting electrolyte imbalances while minimizing risks, such as fluid overload in the context of renal or cardiac compromise. This aligns with the EDIC curriculum's emphasis on evidence-based practice and patient-centered care, ensuring that management decisions are rooted in the best available scientific knowledge and tailored to the individual patient's needs and risks. Incorrect approaches analysis. One incorrect approach involves a passive or reactive strategy, waiting for overt signs of decompensation before initiating significant fluid or electrolyte adjustments. This fails to meet the standard of proactive and preventative care expected in intensive care, potentially leading to delayed recognition of critical imbalances and worse patient outcomes. It neglects the principle of early intervention and the potential for rapid deterioration in critically ill patients. Another incorrect approach is the indiscriminate administration of large fluid boluses without a clear indication of hypovolemia or a dynamic assessment of fluid responsiveness. In a patient with potential cardiac or renal compromise, this can rapidly lead to fluid overload, pulmonary edema, and exacerbation of existing organ dysfunction, directly contravening best practice principles of cautious fluid management. A third incorrect approach is the sole reliance on a single laboratory value, e.g., serum sodium, to guide complex fluid management without considering the patient's overall volume status, renal function, and other electrolyte abnormalities. This oversimplifies a multifaceted problem and can lead to inappropriate interventions that may worsen the patient's condition. It demonstrates a failure to integrate multiple data points into a comprehensive clinical picture. Professional reasoning. Professionals should adopt a structured approach to fluid and electrolyte management. This begins with a thorough initial assessment, followed by continuous monitoring and reassessment. Key considerations include identifying the underlying cause of any imbalance, assessing the patient's volume status using a combination of clinical signs, and, where appropriate, dynamic measures. Interventions should be guided by evidence-based guidelines, with a clear rationale for each fluid or electrolyte order. Regular multidisciplinary team discussions can also be invaluable in complex cases. The EDIC framework emphasizes the integration of scientific knowledge with clinical judgment to optimize patient care and minimize iatrogenic harm. Question 14. Strategic planning requires a comprehensive approach to managing critically ill patients. When faced with a patient on mechanical ventilation exhibiting a pH of 7.28, PaCO2 of 30 mmHg, and HCO3 of 15 mx/L, what is the most appropriate initial step in interpreting these arterial blood gas results to guide management? Option A. Immediately increase the minute ventilation to correct the low pH, assuming a primary respiratory acidosis. Option B. Systematically assess the acid-base disturbance by evaluating the pH, PaCO2, and HCO3 in conjunction with the patient's clinical presentation and ventilator settings. Option C. Interpret the low HCO3 as indicative of a metabolic acidosis and initiate bicarbonate infusion without further assessment. Option D. Focus solely on the low PaCO2 as the primary driver of the acid-base imbalance and adjust ventilator settings accordingly. The correct answer is B. Systematically assess the acid-base disturbance by evaluating the pH, PaCO2, and HCO3 in conjunction with the patient's clinical presentation and ventilator settings. Explanation. The scenario presents a common but critical challenge in intensive care. Interpreting arterial blood gas AB results in a patient with complex, evolving physiology. The professional challenge lies in synthesizing multiple data points, pH, PaCO2, PaO2, HCO3, base excess, with the patient's clinical presentation, ventilator settings, and underlying conditions to guide immediate therapeutic interventions. This requires not just knowledge of ABG interpretation, but also a nuanced understanding of the dynamic interplay between respiratory and metabolic systems, and the potential impact of interventions. Careful judgment is required to avoid misinterpreting the data, leading to inappropriate treatment and potential patient harm. The correct approach, which involves a systematic, step-by-step interpretation of the ABG, correlating findings with the patient's clinical status and ventilator settings, represents best professional practice. This aligns with the principles of evidence-based medicine and patient-centered care, which are fundamental to the European Diploma in Intensive Care Medicine EDIC framework. Specifically, it emphasizes a thorough, integrated assessment rather than a superficial or isolated interpretation of individual values. This methodical approach ensures that all relevant factors are considered, minimizing the risk of diagnostic error and optimizing patient management. An incorrect approach that focuses solely on a single parameter, such as the pH, without considering the other components of the ABG and the clinical context, represents a significant regulatory and ethical failure. This oversimplification can lead to misdiagnosis of the underlying acid-base disturbance, e.g., mistaking a compensated metabolic alkalosis for a primary respiratory alkalosis, and consequently, inappropriate treatment. For instance, if a clinician only focuses on a low pH and initiates aggressive hyperventilation without assessing the PaCO2 and HCO3, they might worsen a metabolic acidosis or induce a dangerous respiratory alkalosis. Another incorrect approach might be to solely rely on automated interpretations from the blood gas analyzer without critical clinical correlation. This fails to acknowledge the limitations of the machine and the crucial role of clinical judgment, potentially overlooking subtle but significant clinical cues or confounding factors not captured by the analyzer. Ethically, this constitutes a failure to provide competent care, as it bypasses essential clinical reasoning. The professional reasoning process for similar situations should involve a structured approach. 1. Assess the patient's overall clinical status, including vital signs, level of consciousness, and any signs of organ dysfunction. 2. Review the current ventilator settings and any recent changes. 3. Systematically interpret the ABG. Determine the primary acid-base disturbance by looking at pH, PaCO2, and HCO3. Assess the degree of compensation. Evaluate oxygenation, PaO2 and SaO2. Consider the base excess for metabolic derangements. 4. Correlate the ABG findings with the clinical picture and ventilator settings. Are the ABG results consistent with the patient's presentation and management? 5. Formulate a differential diagnosis for the observed acid-base disturbance. 6. Develop a targeted therapeutic plan, considering the potential impact of interventions on the acid-base balance and oxygenation. 7. Reevaluate the patient and repeat ABGs as necessary to monitor the response to treatment. This systematic, integrated approach ensures that clinical decisions are evidence-based, patient-specific, and ethically sound, adhering to the high standards expected of intensive care physicians. Question 15. The evaluation methodology shows a 65-year-old male admitted to the ICU with severe sepsis and acute respiratory distress syndrome ARDS. His arterial blood gas, ABGA analysis reveals a pH of 7.25, PaCO2 of 30 mmHg, and PaO2 of 70 mmHg on 10 L/min of oxygen via nasal cannula. The attending physician is reviewing these results. Which interpretation best reflects a comprehensive and clinically relevant approach to this ABG? Option A. The patient has a significant respiratory alkalosis with mild hypoxemia, requiring immediate reduction in oxygen therapy. Option B. The patient presents with a primary respiratory alkalosis superimposed on a metabolic acidosis, indicating adequate ventilation but a significant underlying metabolic derangement. Option C. The patient demonstrates a primary respiratory alkalosis with mild hypoxemia, suggesting effective mechanical ventilation or spontaneous breathing effort contributing to CO2 clearance. Option D. The patient exhibits a mixed acid-base disorder with a primary respiratory alkalosis and a secondary metabolic acidosis, necessitating aggressive fluid resuscitation and vasopressor support. The correct answer is A. The patient has a significant respiratory alkalosis with mild hypoxemia, requiring immediate reduction in oxygen therapy. Explanation. The evaluation methodology shows that interpreting common laboratory tests in intensive care requires a nuanced understanding that goes beyond simple numerical values. This scenario is professionally challenging because critically ill patients often present with complex, multifactorial derangements, making it difficult to isolate the cause of an abnormal result. The EDIC curriculum emphasizes a holistic approach, integrating laboratory findings with clinical presentation, patient history, and other diagnostic data. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based interpretation that considers the entire clinical picture. This aligns with the EDIC focus on developing competent intensivists who can make sound clinical judgments under pressure, adhering to established guidelines for patient care and diagnostic reasoning. The European Resuscitation Council guidelines, for instance, stress the importance of interpreting blood gas analysis in the context of the patient's ventilation, oxygenation, and acid-base status, rather than in isolation. An incorrect approach that focuses solely on a single abnormal value without considering the clinical context is professionally unacceptable. This could lead to misdiagnosis, delayed or inappropriate treatment, and potentially harm to the patient. Such an approach fails to meet the ethical obligation of providing competent care and may violate principles of good medical practice, which mandate comprehensive assessment. Another incorrect approach that relies on anecdotal experience or outdated protocols without referencing current evidence-based guidelines is also problematic. This can lead to suboptimal patient management and a failure to adopt best practices, which are continuously evolving in intensive care medicine. The professional decision-making process for similar situations should involve a structured approach. First, recognize the abnormality. Second, consider the patient's current clinical status and recent events. Third, review other relevant laboratory data and imaging. Fourth, consult current, evidence-based guidelines and literature. And finally, formulate a differential diagnosis and management plan, reassessing as new information becomes available. This iterative process ensures that interpretations are robust and clinically relevant. Question 16. Assessment of a 65-year-old patient with acute respiratory distress syndrome, ARDS, on mechanical ventilation reveals persistent hypoxemia and significant patient effort to trigger breaths, despite a tidal volume of 6 ml/kg ideal body weight and a PEEP of 12 cm H2O. The patient is currently on assist control ventilation. Considering the principles of ARDS management and patient ventilator synchrony, which adjustment to the ventilatory strategy would best address the patient's current clinical state? Option A. Increase the fraction of inspired oxygen, FiO2, and maintain assist control ventilation with the current settings. Option B. Transition to synchronized intermittent mandatory ventilation, SIMV, with a reduced mandatory rate and initiate pressure support for spontaneous breaths. Option C. Switch to pressure-controlled ventilation with a higher peak inspiratory pressure. Option D. Decrease the positive end expiratory pressure, PEEP, to improve lung compliance. The correct answer is B. Transition to synchronized intermittent mandatory ventilation, SIMV, with a reduced mandatory rate and initiate pressure support for spontaneous breaths. Explanation. This scenario presents a common challenge in intensive care, optimizing mechanical ventilation for a patient with evolving respiratory failure. The professional challenge lies in accurately assessing the patient's ventilatory needs and selecting the most appropriate mode to support their breathing, while minimizing ventilator-induced lung injury and patient-ventilator asynchrony. The EDIC curriculum emphasizes a thorough understanding of different ventilation modes and their physiological effects, requiring clinicians to move beyond rote application and engage in critical thinking based on patient-specific data. The correct approach involves a nuanced understanding of how assist control, AC, synchronized intermittent mandatory ventilation, SIMV, and pressure support, PS, interact with patient effort and lung mechanics. AC provides full ventilatory support, delivering a set tidal volume or pressure with each breath, whether triggered by the patient or the ventilator. SIMV allows for spontaneous breaths between mandatory breaths, which can be beneficial for weaning, but may lead to increased work of breathing if spontaneous breaths are not adequately supported. PS augments spontaneous breaths with a set level of pressure, reducing the patient's inspiratory effort. The optimal choice depends on the patient's respiratory drive, tidal volume requirements, and the goal of ventilation, e.g., full support, weaning, or reducing work of breathing. An incorrect approach would be to rigidly apply a single mode without reassessing the patient's response. For instance, continuing AC with high tidal volumes in a patient who is starting to generate significant spontaneous effort could lead to volatrauma and barotrauma. Similarly, using SIMV without adequate pressure support for spontaneous breaths could result in significant patient-ventilator asynchrony and increased work of breathing, potentially hindering weaning. A failure to consider the patient's evolving clinical status and adjust the ventilation strategy accordingly represents a lapse in professional judgment and a deviation from best practice as outlined by critical care guidelines that prioritize patient safety and optimal outcomes. The professional decision-making process should involve a continuous cycle of assessment, intervention, and reassessment. This includes 1. Evaluating the patient's respiratory drive, tidal volumes, respiratory rate, and oxygenation. 2. Considering the underlying pathology and the goals of mechanical ventilation. 3. Selecting the most appropriate mode based on these factors, understanding the principles of each mode. 4. Closely monitoring the patient's response to the chosen mode, looking for signs of improvement or deterioration, and assessing for patient ventilator synchrony. And 5. Being prepared to adjust the mode or settings as the patient's condition changes. This iterative process ensures that mechanical ventilation remains a supportive therapy rather than a source of harm. Question 17. Comparative studies suggest that in patients with moderate to severe acute respiratory distress syndrome, ARDS, optimizing mechanical ventilation to minimize ventilator-induced lung injury, VILI, is paramount. Considering the principles of lung protective ventilation and the potential for heterogeneous lung injury, which of the following ventilatory strategies is most aligned with current European guidelines for managing ARDS? Option A. Utilizing high tidal volumes, 10-12 ml/kg predicted body weight, to ensure robust alveolar expansion and improve oxygenation with minimal PEEP. Option B. Prioritizing pressure-controlled ventilation with a high respiratory rate to reduce the work of breathing without specific attention to tidal volume or driving pressure. Option C. Setting a fixed high PEEP level e.g. 20 cm H2O regardless of lung compliance to maximize alveolar recruitment, accepting potentially higher peak airway pressures. Option D. Employing a low tidal volume, 6-8 ml/kg predicted body weight, with individualized PEEP titration to achieve adequate alveolar recruitment and minimize lung strain while monitoring driving pressure. Correct answer is D. Employing a low tidal volume, 6-8 ml/kg predicted body weight, with individualized PEEP titration to achieve adequate alveolar recruitment and minimize lung strain while monitoring driving pressure. Explanation. This scenario presents a common clinical challenge in intensive care, optimizing mechanical ventilation for a patient with acute respiratory distress syndrome, ARDS, to minimize ventilator-induced lung injury, VILI, while ensuring adequate gas exchange. The professional challenge lies in balancing the risks and benefits of different ventilatory strategies, considering the heterogeneity of lung injury in ARDS and the potential for unintended consequences. Careful judgment is required to select a strategy that is both evidence-based and tailored to the individual patient's physiological state. The correct approach represents best professional practice by adhering to established guidelines for ARDS management, which emphasize lung protective ventilation. This includes using low tidal volumes and appropriate positive end expiratory pressure, PEEP, to recruit alveoli and prevent alveolar collapse, thereby reducing shear stress in VILI. The European Resuscitation Council, ERC, guidelines, which are relevant to the EDIC examination, advocate for these principles. The ethical imperative to do no harm, non-maleficence, strongly supports strategies that minimize iatrogenic injury. An incorrect approach involving the use of high tidal volumes without adequate PEEP would be professionally unacceptable. This would directly contravene the principles of lung protective ventilation and significantly increase the risk of VILI, leading to further lung damage and potentially worse outcomes. This represents an ethical failure to uphold the principle of non-maleficence and a failure to adhere to evidence-based best practices as outlined in relevant European critical care guidelines. Another incorrect approach, such as relying solely on pressure-controlled ventilation without considering lung mechanics and driving pressure, could also be problematic. While pressure control can be useful, if not managed appropriately with attention to delivered tidal volumes and lung compliance, it can lead to volatrauma or barotrauma. This would be a failure to apply a comprehensive understanding of ventilatory mechanics and a deviation from best practice that prioritizes minimizing lung stress. A further incorrect approach might involve prematurely weaning from mechanical ventilation in a patient with ongoing ARDS without adequate assessment of respiratory muscle strength and gas exchange. This could lead to respiratory failure, reintubation, and increased morbidity. This represents a failure in clinical assessment and a potential breach of the duty of care to ensure patient stability before discontinuing life support. The professional decision-making process for similar situations should involve a systematic assessment of the patient's respiratory status, including arterial blood gases, lung mechanics, compliance, resistance, and driving pressure. This should be followed by a review of current evidence-based guidelines for ARDS management. The chosen ventilatory strategy should then be implemented with continuous monitoring and frequent reassessment to allow for timely adjustments based on the patient's response and to minimize the risk of VILI. Question 18. Cost-benefit analysis shows that while novel biomarkers for critical illness are emerging, their widespread adoption requires careful consideration of clinical utility and resource implications. Which approach best reflects evidence-based practice and responsible resource stewardship in the intensive care unit? Option A. Rely primarily on clinical judgment and avoid the use of most biomarkers due to their perceived high cost and potential for ambiguity. Option B. Routinely order a broad panel of novel biomarkers for all critically ill patients to ensure no potential diagnostic clue is missed. Option C. Prioritize the use of the most recently published biomarkers, assuming they represent the cutting edge of diagnostic capability, regardless of cost or established validation. Option D. Systematically evaluate the evidence for specific biomarkers in relation to the suspected diagnosis and their demonstrated impact on patient management and outcomes, considering cost-effectiveness. The correct answer is D. Systematically evaluate the evidence for specific biomarkers in relation to the suspected diagnosis and their demonstrated impact on patient management and outcomes, considering cost-effectiveness. Explanation. This scenario presents a common challenge in intensive care medicine: the judicious use of diagnostic tools in the context of resource limitations and evolving clinical understanding. The professional challenge lies in balancing the potential diagnostic utility of biomarkers against their cost, the invasiveness of sample collection, and the potential for misinterpretation or over-reliance. Careful judgment is required to ensure that biomarker use aligns with evidence-based practice and contributes meaningfully to patient care without unnecessary expenditure or patient burden. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based evaluation of biomarker utility in the specific clinical context. This aligns with the principles of good medical practice and resource stewardship, which are implicitly expected within the European framework for intensive care medicine. Focusing on biomarkers with established prognostic or diagnostic value in the suspected condition, and considering their impact on clinical decision-making, ensures that their use is justified and contributes to improved patient outcomes. This approach respects the ethical imperative to provide effective care while being mindful of healthcare system resources. An incorrect approach that relies solely on the availability of a novel biomarker without considering its validated clinical utility or cost-effectiveness is professionally unacceptable. This could lead to unnecessary investigations, increased healthcare costs, and potential patient harm through false positives or delayed diagnosis of the true underlying pathology. It fails to adhere to the principle of evidence-based medicine and responsible resource allocation. Another incorrect approach that involves routine, indiscriminate testing of multiple biomarkers for every critically ill patient, regardless of clinical suspicion, is also professionally unsound. This approach disregards the specific needs of individual patients, the potential for information overload, and the significant financial implications. It deviates from best practice by not tailoring diagnostic strategies to the clinical presentation and by failing to consider the potential for harm from overinvestigation. The professional decision-making process for similar situations should involve a structured approach. 1. Clinical assessment. Thoroughly evaluate the patient's signs, symptoms, and history to formulate a differential diagnosis. 2. Evidence review. Consult current guidelines and peer-reviewed literature to identify biomarkers with proven diagnostic, prognostic, or therapeutic monitoring value for the suspected conditions. 3. Contextualization. Consider the specific clinical context, including the patient's comorbidities, the stage of illness, and the availability of other diagnostic modalities. 4. Cost-benefit consideration. Evaluate the cost of the biomarker test against its potential clinical benefit and impact on patient management and outcomes. 5. Shared decision-making, where appropriate, involve the patient or their surrogate in the decision-making process regarding investigations. 6. Reevaluation. Continuously reassess the utility of biomarkers as new evidence emerges or the patient's condition evolves. Question 19. To address the challenge of managing acute respiratory failure in an intensive care setting, a clinician is evaluating the optimal initial ventilatory strategy for a patient presenting with moderate hypoxemia and increased work of breathing. But who is alert and cooperative? Which of the following approaches best reflects current European best practice in intensive care medicine regarding invasive and non-invasive techniques? Option A. Immediately initiate invasive mechanical ventilation via endotracheal intubation to ensure definitive airway control and optimal gas exchange. Option B. Conduct a thorough assessment for contraindications to non-invasive ventilation, NIV, and if absent, initiate NIV with close monitoring for response and potential escalation to invasive ventilation. Option C. Proceed directly to tracheostomy to facilitate long-term ventilatory support and patient comfort, bypassing endotracheal intubation. Option D. Administer high-flow nasal oxygen therapy as the sole intervention, deferring both NIV and invasive ventilation until the patient's condition significantly deteriorates. The correct answer is A. Immediately initiate invasive mechanical ventilation via endotracheal intubation to ensure definitive airway control and optimal gas exchange. Explanation. This scenario presents a common challenge in intensive care, balancing the need for effective respiratory support with the potential risks and patient comfort associated with invasive procedures. The professional challenge lies in accurately assessing the patient's condition, predicting the likelihood of successful non-invasive ventilation, and understanding the specific indications and contraindications for both invasive and non-invasive techniques within the European context of intensive care practice. The decision requires a nuanced understanding of physiological parameters, patient factors, and the available evidence base, all while adhering to established clinical guidelines and ethical principles. The correct approach represents best professional practice because it prioritizes a thorough, evidence-based assessment of the patient's suitability for non-invasive ventilation, NIV, before resorting to intubation. This aligns with the principle of least harm and patient autonomy, aiming to avoid the complications associated with invasive procedures whenever possible. Guidelines from European professional bodies emphasize the judicious use of NIV for appropriate indications, such as acute hypoxemic respiratory failure or exacerbations of COPD, provided there are no contraindications. This approach involves careful monitoring of respiratory rate, work of breathing, oxygenation, and mental status. The decision to proceed with NIV should be based on a clear understanding of its potential benefits and limitations in the specific patient context. An incorrect approach would be to immediately proceed with intubation without a comprehensive trial of NIV, especially if the patient's condition is not immediately life-threatening and NIV is a viable option. This fails to adhere to the principle of minimizing invasiveness and could lead to unnecessary complications such as ventilator-associated pneumonia, barotrauma, and prolonged mechanical ventilation. Another incorrect approach would be to initiate NIV without adequately assessing for contraindications, such as hemodynamic instability, severe encephalopathy, or copious secretions, which could lead to treatment failure and delayed definitive airway management. Furthermore, failing to have a clear escalation plan if NIV is unsuccessful would also be a significant professional failing, as it demonstrates a lack of foresight and preparedness for potential deterioration. Professional decision-making in such situations should follow a structured approach. First, a rapid but thorough assessment of the patient's respiratory status and overall clinical condition. Second, identification of potential indications and contraindications for both NIV and invasive ventilation. Third, consideration of the patient's wishes and prior directives if known. Fourth, selection of the most appropriate initial ventilatory strategy based on evidence and clinical judgment. And finally, continuous reassessment and adaptation of the strategy based on the patient's response and evolving clinical picture. Question 20. Market research demonstrates a growing demand for specialized critical care services across Europe, prompting a review of existing ICU organizational structures. A large teaching hospital is considering how to best adapt its ICU to meet these evolving needs, aiming to enhance patient outcomes and operational efficiency. Which of the following approaches would represent the most effective and compliant strategy for restructuring the ICU? Option A. Conduct a comprehensive review of current ICU performance metrics, benchmark against leading European ICUs, and engage a multidisciplinary team to develop a revised organizational model based on evidence and stakeholder input. Option B. Invest in the latest advanced monitoring and life support technologies, assuming that technological superiority will inherently improve patient care and streamline operations. Option C. Delegate the entire restructuring process to the lead intensivist, empowering them to implement changes based on their personal experience and perceived best practices. Option D. Implement minor adjustments to existing protocols and staffing schedules based on informal feedback from a few senior nurses, without a formal evaluation of current performance or external benchmarks. The correct answer is A. Conduct a comprehensive review of current ICU performance metrics, benchmark against leading European ICUs, and engage a multidisciplinary team to develop a revised organizational model based on evidence and stakeholder input. Explanation. This scenario presents a common implementation challenge in healthcare, specifically within the context of intensive care unit (ICU) organization and structure, as governed by European standards and guidelines relevant to the EDIC. The core difficulty lies in balancing the need for specialized, high-acuity care with the practicalities of resource allocation, staff expertise, and patient flow within a complex hospital system. The EDIC framework emphasizes evidence-based practice, patient safety, and efficient resource utilization, all of which are tested in this question. Correct approach represents best professional practice because it prioritizes a structured, multidisciplinary, and evidence-based methodology for redesigning ICU services. This aligns with the EDIC emphasis on continuous quality improvement and adherence to established European guidelines for critical care. A systematic review of current practices, benchmarking against leading European ICUs, and engaging all relevant stakeholders, clinicians, nurses, administrators, and potentially patient representatives, ensures that any proposed changes are well-informed, feasible, and likely to improve patient outcomes and operational efficiency. This approach fosters a culture of learning and adaptation, crucial for maintaining high standards in intensive care. An incorrect approach that focuses solely on technological upgrades without addressing underlying organizational or staffing issues would be professionally unacceptable. This fails to recognize that technology is a tool, not a solution in itself, and can exacerbate existing problems if not integrated thoughtfully into the care delivery model. It neglects the human element and the critical importance of skilled personnel and efficient workflows, which are central to effective ICU management and patient safety as espoused by EDIC principles. Another incorrect approach that involves unilateral decision-making by a single department or individual without broad consultation would also be professionally unsound. This violates principles of collaborative healthcare and can lead to resistance, overlooked critical perspectives, and ultimately, suboptimal outcomes. Effective ICU organization requires buy-in and input from all affected parties to ensure comprehensive and sustainable improvements. Such an approach disregards the interconnectedness of services within a hospital and the need for a holistic view of patient care pathways. Finally, an approach that relies on anecdotal evidence or past practices without rigorous evaluation would be a significant regulatory and ethical failure. The EDIC curriculum stresses the importance of evidence-based medicine and adherence to current best practices. Implementing changes based on outdated or unverified information risks compromising patient safety and the quality of care, directly contravening the core tenets of intensive care medicine as promoted by the EDIC. The professional decision-making process for similar situations should involve a structured problem-solving framework. This typically includes defining the problem clearly, gathering comprehensive data, including patient outcomes, resource utilization, and staff feedback, identifying potential solutions, evaluating these solutions against established criteria, evidence-based practice, feasibility, cost-effectiveness, patient safety, implementing the chosen solution with a clear plan, and finally, monitoring and evaluating the impact of the changes, making adjustments as necessary. This iterative process ensures that decisions are data-driven, ethically sound, and aligned with the highest standards of critical care.